Hello, my name is Phil Rawls, and I'm a professor of radiology at the University of Southern California, Keck School of Medicine, and I work at LA County USC Medical Center. I'm going to be talking to you today about diffuse liver disease and the sonographic evaluation of it. Hello, I'm going to talk to you today about diffuse liver disease, some of the pitfalls that you might encounter, and some of the hints as well. I'm not going to cover a lot of the basic information because you already know that. I'm from California, and so the obligatory surfing slide is here. First, talk about acute hepatitis, and generally we're talking about hepatitis A here. Acute hepatitis is really a clinical diagnosis, and we don't really require imaging to make the diagnosis. The labs, however, can be confusing, and we can have elevated or normal labs, which will prompt clinical confusion and therefore an ultrasound examination. The first thing I'd like to talk to you about is what I call the myth of the starry sky in acute hepatitis. Many people believe that increased periportal echoes coupled with decreased parenchymal echogenicity is virtually diagnostic for acute hepatitis, and this in fact is not true. The findings with respect to the periportal echoes are related to normal anatomic variability because of the variations in the amount of periportal fat, not related to the hepatitis. And in fact, this has been shown to be true in a blinded study that was done in Italy some time ago, where they did a study of 791 patients, and only 19 of the patients with acute hepatitis had this pattern. And in a control group comparing normals and patients with hepatitis, there was no difference whatsoever in the frequency of this finding. So the starry sky is not something that you ought to pay attention to. Here's an example of the starry sky. Of course, there is such a thing as the starry sky, as we see in this Vincent van Gogh painting. There is one little hint that can be useful to you, however, in acute hepatitis, in that often these patients will have a very edematous, thickened gallbladder wall. Some people call this a striated gallbladder wall, and this can actually suggest the diagnosis of acute hepatitis. In fact, this is usually or often the only ultrasound abnormality in acute hepatitis. Here's an example of hepatitis A, and I'll use the mouse as a pointer. And you can see that here we have the submucosa, and this is a massively thickened wall with a small lumen. And this is a hepatitis A patient. Here's another hepatitis A patient whose gallbladder essentially has no lumen. It's totally obliterated because of the wall thickening. One thing that is also useful is if you have significant gallbladder wall thickening with a very small gallbladder lumen, less than 15 millimeters, this should suggest a non-intrinsic cause of gallbladder wall thickening, that is to say, an abnormality not related to gallbladder disease itself. There are other things, of course, that cause gallbladder wall thickening. Here's an example of a cirrhotic patient who has a low albumin and portal hypertension. And we see the ascites and the thickened gallbladder wall, both of which are caused by the cirrhosis. Here's another patient who has cardiac disease and a thickened gallbladder wall with a very small lumen. Here's a less usual cause of gallbladder wall thickening, and that's infectious mononucleosis. And there are other things that can do this too. Of course, this small lumen rule doesn't always work. Here's a patient who has a lumen that's larger than 1.5 centimeters and a thick wall, and this is a patient who's cirrhotic and has portal hypertension and a low serum albumin. Here's a patient who actually has acute cholecystitis that looks sort of like the cases that I've already shown you. This patient happens to have a small gallbladder wall lumen and a thick wall. So the rules are not perfect. Here's the same patient who has cystic duct stone in this particular video clip. So the rules are not perfect, but they work reasonably well. So we do have fires in Los Angeles, and I just put this in as an example of that. All right, let's talk about fatty liver. Fatty liver is becoming an increasingly recognized health issue, especially in the United States, and elsewhere too, of course. It's a common condition and has many different causes. The actual pathway to fatty liver is poorly understood, but there are many conditions that are associated with it. I've listed some of them here: alcohol, diabetes, obesity, malnutrition, drugs, and many others. One concern is the so-called non-alcoholic fatty liver disease, or NAFLD. And in the U.S., this is the hot diagnosis in hepatology. You can get progression from fatty liver to what's called NASH, which is steatohepatitis, where you have actual liver inflammation with a fatty liver, and then NASH with fibrosis, which can lead to cirrhosis. And in fact, fatty liver disease is probably going to be one of the major causes of cirrhosis in the United States. And here's an algorithm that I'll leave up for a moment or two for those of you who want to look at this. Hopefully you can review it. And there's a reference from where this came, talking about the progression of fatty liver disease and natural history of non-alcoholic fatty liver disease. Now, there's no problem making the diagnosis of severe fatty liver disease. Basically, this is the classic situation where you have markedly increased liver echogenicity and visible attenuation of the sound. This is only seen, however, in a minority of the most severe cases. In this circumstance, the diaphragm is poorly seen and the vessels in the liver are indistinct. Here's an example of such a case where there's obvious severe attenuation. We can barely see the diaphragm. But this is the severe case, which is not really terribly difficult to diagnose. It's more important to make the diagnosis of mild fatty liver because we want to catch the fatty liver disease early so that perhaps something can be done to mitigate the potential complications of the illness. The way that we make this diagnosis, there are several actually, but one is to compare the spleen and the liver, not so much directly, but using the kidney as an internal standard, and I'll show you what I mean by this. Normally the spleen is more echogenic than the liver, but ordinarily you can't compare them directly. Now, here's a circumstance. This is an anatomic variant where the left lobe of the liver overlaps the spleen here. And in this particular circumstance, you can compare them directly, and it allows us to see the echogenicity patterns. So this is a long axis scan in the left upper quadrant. And here's this liver overlapping the spleen. And notice how the liver, this normal liver, is more echogenic than the spleen. And of course, both are more echogenic than the renal cortex. So that's the normal situation. Now here's another patient with a similar anatomic variant with the liver overlapping the spleen, but in this circumstance, the liver is more echogenic than the spleen. So this is fatty liver. It would be nice if we could directly compare the spleen and the liver in all patients, but it's only possible in a minority. Therefore, we have to use the kidney to help us. Basically, what we do is to compare the liver and the spleen to the kidneys. And if the liver to right kidney echogenicity is greater, than the difference is greater than the echogenicity of the spleen compared to the left kidney, fatty liver is present. So if the liver looks more relatively echogenic to the kidney than does the spleen, that's abnormal. And here's one such example. On the right, we see that there is a fairly pronounced difference in echogenicity between the liver and the right kidney. On the left, however, the spleen is not nearly so different from the renal cortical echogenicity. So this is diagnostic of fatty liver and is an aid to making the diagnosis in more subtle cases. Another important thing to look at is fatty sparing, or for that matter, focal fat. These entities can be diagnostic of fatty liver, and they can also create problems by simulating a mass, and one needs to be aware of both of these features. Here's an example of a patient who has very prominent sparing in this otherwise fatty liver, and this is often confused for a mass, and you don't really want to go ahead and do additional imaging that isn't necessary when you have a finding that it's actually typical. It's just a question of learning how to recognize what's typical and what's not. Here's a typical area of increased echogenicity related to focal fat, which is, of course, a different situation, and this too can simulate a mass. So variations locally in fat can simulate masses, and one needs to be a bit careful about that. Here's a combination. Basically, this patient has an area of focal fat and peripheral hypoechogenicity, which is sparing. So this almost looks like a lesion with a halo, but this is in fact just fatty, focal fat and sparing around it. Here's another one. This is, I think this is actually the same patient who has this central hypoechoic area and peripheral increased echogenicity. Now, not everything that contains fat is innocuous, okay? And here's a patient who has hepatocellular carcinoma, and we can see on this non-contrast scan that there's a definite fatty component to this HCC. HCC is one liver lesion that has fat in it focally, not terribly infrequently. And here's the corresponding ultrasound with the less affected soft tissue area and the echogenic fatty area. In the next example, we see a contrast enhanced scan where the fatty area doesn't enhance, but the other area enhances quite prominently. And on the color Doppler, we can see that the fatty area does not enhance, but there's very prominent increased flow within the solid, more non-fatty affected component of this hepatocellular carcinoma. So the next point I want to make, which is germane to the diagnosis of fatty liver, is that if you have classic spared areas, these are diagnostic for fatty liver. And this is true even when the overall liver echogenicity is normal. These are some of the areas that are classically affected by sparing. And you can see basically it is the posterior or dorsal portion of the left lobe, ventral to the bifurcation of the portal vein, along the fissure for the ligamentum venosum. And here's an example of this, ventral to the portal vein bifurcation. Here's the left portal vein, right portal vein. In this sort of classic pyramidal or triangular shaped area is very typical for sparing and is diagnostic for fatty liver. Down a little bit more caudal, you see the same dorsal left lobe sparing. And of course the gallbladder region is another area that is commonly affected by sparing. And here's one such gallbladder that has a very prominent spared area. Again, don't confuse this for a mass. This is diagnostic for fatty liver. Here's a long axis view. And here again we have sparing adjacent to the gallbladder. And one pitfall here that isn't always appreciated is that people will confuse this for either thickening of the gallbladder wall or more significantly, a pericholecystic abscess. This is focal sparing and should not be confused for anything else. Now here's a classic spared area, diagnostic of fatty liver, but here's a case that's more problematic, and we have a large liver here, but it's not obviously a fatty liver from the images that we have here. However, when we look around a little bit, we see that there is in fact a classic spared area anterior to the porta hepatis, portal vein bifurcation region, and this is thus definitively fatty infiltration of the liver. So sparing alone is enough to make the diagnosis of fatty liver. Let's move on to cirrhosis. Cirrhosis has many causes: alcohol abuse, hepatitis B, hepatitis C, and many other causes, including progression of non-alcoholic fatty liver disease. This is the wine that the patients at the county hospital in Los Angeles prefer, first growth Bordeaux, etc. The primary diagnostic criterion that we use for cirrhosis is a nodular liver surface. To a lesser extent, we use the shape of the liver, the morphology, where you can have a small right lobe and a large caudate lobe, or in my view, an even more useful finding is an enlarged lateral segment of the left lobe, especially when the surfaces are biconvex. Here's an example of a 3D image of a nodular surface in a patient with ascites. And you can see this quite nicely. Unfortunately, we can't get images like this all the time. It's easy to make the diagnosis of surface nodularity when we have ascites, as we do in this case. And this is quite readily diagnosable. But when there's no ascites, it can be harder. Here's a patient who has a large left lobe, small right lobe, and this is, again, cirrhotic morphology. and certainly suggestive of cirrhosis. A little bit about liver surface nodularity. A lot of people think that looking at the nodularity of the liver is useless. However, if you use this sign properly, it's quite useful. There's no question that it is an insensitive sign. Now, what does that mean? It means basically that you will encounter many people who have cirrhosis who do not have an apparently nodular surface. This is largely people who have micronodular cirrhosis. Technique is important in trying to elicit whether or not there is nodularity. And one thing that you don't want to do is scan between the ribs and the right lobe. We always scan ventrally in the midline using a high-resolution transducer to see the anterior surface of the left lobe. So one pitfall is with regard to liver surface nodularity is that it has a very good positive predictive value, but it's insensitive. So that means if you have an unequivocally nodular liver surface, you can pretty much take it to the bank, with some exceptions, that the patient has cirrhosis. However, it's mandatory to view this either at real time or with video clips to make the diagnosis more secure. Looking at still images, frozen images, doesn't work very well. So what do? We use a high-frequency linear array transducer, although occasionally you can get away with the curved linear transducer if the resolution is good enough. And we scan longitudinally in the midline, looking for the ventral surface of the left lobe of the liver. And as I said, real-time images or clips are mandatory in doing this. You have to be careful to hold the transducer so that the beam is at 90 degrees to the liver surface, because if it's not at 90 degrees, you can get erroneous results. Here's a nodular liver surface with a high-resolution transducer, and I don't think anyone would dispute that this is nodular, and this has a good predictive value for cirrhosis. Now, this is a patient who has liver nodularity, but it's not seen very well because we're using our lower resolution abdominal transducer. Here's the same patient with a high resolution transducer, and you can see how much more clearly it's seen. So technique's important. Sometimes you will see it with a curved linear array if it's a modern transducer, and I think you can appreciate the liver surface nodularity. We have to do this sometimes in patients who are fat or have other body habitus problems that prevents us from seeing things well with the high-resolution transducer. So next hint, liver surface nodularity. Scan the ventral left lobe in the midline. Look at the surface. And you have to do this either scanning it at real time or with video clips. Hold the transducer at 90 degrees to the liver surface if you want to get a reliable result. And here is here's a scan that sort of shows you why I don't like scanning intercostally on the right. And this doesn't really show any nodularity whatsoever scanning over in this location. However, there is nodularity seen, this is very subtle, but it's real, of the ventral left lobe. So scan the ventral left lobe, not the right lobe. The reason we don't, as I said, to emphasize again, scan intercostally, is that it's less sensitive and there are fewer true positives. The one exception to this is when there's a small amount of ascites present, sometimes you can actually see the liver surface better on the right. So if there's ascites out laterally, that can be good and can allow you to make the diagnosis, especially if there's no ascites medially. Now here's one such case that's showing us the nodularity to better advantage with the ascites. Here's another case where the liver surface looks smooth on the left lobe, but looks nodular with ascites through the ribs. So there are exceptions to this, as there are to almost all rules, but in general, left lobe is where you want to be. Now, cirrhosis is not the only cause of nodular liver surface. You can get this with multiple liver tumors, metastatic disease, HCC. You can get it with peritoneal carcinomatosis, where there are implants on the surface of the liver that can cause difficulties. You can get it with acute massive hepatic necrosis, but this is rare, and because we don't usually get these people in ultrasound. Here's a patient who has neuroendocrine metastases and nodularity because of the focal liver lesions, not cirrhosis. And here's another one. This is a nodular liver surface. This patient does not have any liver disease per se, but rather has implants along the surface because of the carcinomatosis from breast carcinoma. Now, just to emphasize, I think that you need to be careful to only say that the liver surface is nodular if it is definitely nodular. If you're not sure that it's nodular, don't call it nodular, because you want to have a very high predictive value for surface nodularity to predict cirrhosis. All right, let's talk about other diagnostic criteria for cirrhosis. We use surface nodularity primarily. There are the only other really strong criterion that we use for cirrhosis is the presence of portosystemic collaterals. Other abnormalities, such as portal venous flow abnormalities, flow reversal, biphasic flow, slow flow, sometimes associated with enlarged arteries, are intermediate in strength. And the least specific signs are things like splenomegaly, gallbladder wall thickening, and ascites. So it's important to remember that in portal hypertension, the ultrasound may be normal. If we see any of these abnormalities like collaterals, flow reversal, etc., arterial enlargement, they're suggestive, but not necessarily definitive and not always present. Here's a very large portal venous to hepatic venous collateral. This is seen in cirrhosis and other conditions sometimes. Here's a patient who has, on this longitudinal image, a large coronary vein collateral system. And here is a sketch of this flow reversal in the coronary vein going up to form gastroesophageal varices. Here's that same clip shown inset. A recanalized paraumbilical vein is another common collateral. After the coronary vein collaterals, the left gastric vein collaterals, it is the most common, so it's number 2. Here's a smaller recanalized paraumbilical vein, again diagnostic for portosystemic collateral coming off the left portal vein, going through the ligamentum teres and up and out of the liver. Another type of collateral that is somewhat less common, but when you see it is also important, is a Spleno-Renal collateral. To make this diagnosis, you have to actually see the splenic vein and the renal vein join. Just the presence of big vessels in the splenic hilus is not enough. Here's a patient who has what I call a flank collateral, where there's a big collateral going out between the spleen and left kidney into the region of the flank. This is another common type of portosystemic collateral. Here's an umbilical collateral related to a superficial abdominal vein. So there are a whole bunch of collaterals. Here's an interesting collateral that we'll see several times a year. This is an inferior epigastric vein that's being recruited as a portosystemic collateral going into the external iliac vein, and it's not unusual in this kind of patient for us to be doing a deep venous thrombosis study and to discover collaterals and thus cirrhosis when it was previously unsuspected during a DVT study, which is surprising, I think, to a lot of people. Okay, portal vein flow abnormalities are less specific than portosystemic collaterals, but they can be helpful as well. Slow flow, biphasic flow, flow reversal are all different manifestations of portal hypertension. In the normal course of events, blood flows into the liver via the portal vein and hepatic artery. Then it goes through the sinusoids into the central hepatic vein and out via the hepatic veins and ultimately the inferior vena cava. When there's cirrhosis, there's a fibrotic condition which decreases this flow into the sinusoids. It's sort of a block, if you will, as shown in this sketch. This may lead to flow reversal and concomitant arterial enlargement, as we see here. There is flow reversal in this part of the portal vein. Actually, in this part of the portal vein, the posterior segmental vein, flow is antegrade. So these changes can be regional. Here's another regional abnormality. This is a transverse image of the left portal vein. And blood is flowing in an antegrade fashion here, but in this medial segmental branch, there's flow reversal. And of course, the enlarged arteries are a prominent component in this case. So when you have blockage of the sinusoids, you can get flow reversal because the arterial flow will come in, get blocked through cannot go through the sinusoids, and will exit via the portal veins, engendering flow reversal. Here's another such case. This one is actually biphasic, but the mechanism is pretty much the same. So flow reversal and antegrade flow both in this patient who has large hepatic arteries. Now, hepatic arterial enlargement results whenever there's decreased portal flow, either from portal hypertension or portal occlusion. There are other causes, too, that result from increased arterial blood flow. And we'll talk a little bit about those, like tumors and vascular malformations. So when there's decreased portal flow, I showed you this graphic already, there's increased arterial flow, and the blood can exit the liver via the portal vein. Here's one such example of that. These large vessels that are aliased are arteries. The blue is flow reversal in especially the right portal vein. So this is a sign of portal hypertension in this patient. Actually, you can see the nodular liver and ascites. You get corkscrew arteries in hepatic cirrhosis, this tortuous high flow artery that we're seeing here. However, you can get other causes of arterial enlargement. It doesn't occur just in portal flow abnormalities. It may occur with hepatic tumors and vascular malformations. Here's a vascular malformation that has resulted in increased arterial flow. Here's a patient with Osler-Weber Rondeau, or hereditary hemorrhagic telangiectasia, who has a large common hepatic artery and a massive AV fistula in the liver. Just wanted to thank you very much for giving me the opportunity to present this, and hopefully you've learned a few things of value to you in your practice about diffuse liver disease. If you have any questions that you'd like to ask me, please send me an email and I'd be happy to respond. Thank you.